welcome to this channel made for me. In this video, we will talk about the hemolytic disease of newborn, that is Erythroblastosis Foetalis. So, before starting with this Erythroblastosis Foetalis, I want you to know one thing, that our body have a lot of blood group system. Okay, there are around 30 minor blood group system and two major blood group system. One of them is ABU and second one is the RS. These two group system, they are the major group system. So in RBC, if this is RBC, if in RBC antigen is present, which antigen? RS antigen is present, then it is known as RS positive. Okay, so the person who are having RS antigen in the red blood cell, they are RS positive, and in person who are not having, they are RS negative. And in RS positive, this RS blood group system, the main antigen is the D antigen. Okay, so we can call this RS positive as D positive and RS negative as D negative. Now overall around 60% cases there is RS negative mother and RS positive fetus. So in 60% of the cases, when the mother is RS negative, there can be chance of RS positive fetus in 60% of patient. But in case of India, there is only around 5 to 10%. This data has been taken from the book. Okay, so as there is a high chance of having RS positive fetus in a female who is RS negative, we have to do the antenatal checkup of ABO and RS typing. It is very necessary to do ABO and RS typing in the first antenatal checkup to find out either the mother is RS positive or RS negative. Okay, as we know that if any foreign body or antigen enters to our body, what our body does? Our body prepares an antibody to fight against that antigen. Similar in the case of this hemolytic disease of newborn. What happens? Like here the female is RS negative. Okay, and the fetus is RS positive. So during conditions like third stage of labor, okay, during third stage of labor or during manual removal of placenta, okay, during third stage of labor or during medical termination of pregnancy or during miscarriage, what happens? Some amount of fetal blood, it get transferred to the, it get leaked into the maternal circulation. Okay, some amount of blood leak into which blood? This is the fetal blood. Some amount of fetal blood leaked into maternal circulation. And what type of blood is the fetal blood? It is RS positive, and maternal circulation, it is RS negative. So the maternal circulation, what it does, that it start preparing antibody against this RS positive antigen. Okay, so maternal blood start preparing antibody, against RS positive antigen. So during the first pregnancy, if some amount of blood is leaked into the maternal circulation, then maternal body starts preparing antibody, and that antibody will remain throughout the life in the female body. Okay, so in later pregnancy, if again the fetus is RS positive, then what antibody is already prepared in the maternal circulation. So RS positive fetus is present in the womb, okay, in the uterus. RS positive fetus is present, and the antibody against RS positive antigen is already prepared in the maternal circulation. So all the antibody enter into the fetal circulation in the next pregnancy. Okay, in the next pregnancy, what it does, then it start lot of destruction to the RBC. We will explain in detail later. Okay, first what we have to know that what amount of blood is necessary to start the antibody formation in the fetal circulation. That is at least 0.1 ml blood, 0.1 ml of blood, it should be leaked into the maternal circulation. And this fetus, when it is present in the uterus, it starts preparing the RS antigen. It starts preparing the RS antigen by 38th day after conception. Okay, by 38th day after conception. So it is the 38th day after conception. So if there is the first trimester abortion of or if there is any induced abortion, okay, there can be also chance of leaking of at least 0.1 ml of blood from fetal circulation into the maternal circulation. So it is not only necessary to leak of the blood from the fetal circulation into maternal circulation only during the third stage of labor, or okay, during the delivery or during manual removal of the placenta, but it can leak during the spontaneous or induced abortion also, because this RS antigen is formed in the fetus by 30th day after conception. So any cause like trauma or antepartum hemorrhage or anything, if there is release of blood from the fetal circulation into the maternal circulation after 38th day of conception, then there can be chance of formation of RS positive antibody against the RS positive antigen in the maternal circulation, that will subsequently affect the future pregnancy. Okay, now I have told you that the antibody is formed in the maternal circulation. So let's write that point. So 0.1 ml blood or more blood is leaked into the maternal circulation. Okay, then antibody develop. After how many days? Antibody develop in the maternal circulation after 10 to 16 weeks. Okay, in maternal circulation after 10 to 16 weeks. So what are the two different types of antibody they will be formed? One will be the IgM and another will be IgG. Okay, as the IgM is the first antibody to be formed in the maternal circulation, and it is larger. Okay, and it is larger, so it do not pass through the placental barrier. So it do not pass through placental barrier. If it do not pass through the placental barrier, will it affect the fetus? No, there will be no harmful to the fetus. So this IgM antibody, it will not be harmful to the fetus in subsequent pregnancy. But what about IgG? IgG is smaller. Okay, IgG is smaller, so it can pass. So it can cross the placental barrier. So it can cross the placental barrier. If it crosses the placental barrier, what it will cause? It will damage the fetus. Okay, what type of damage will happen, we'll talk later on. Let's imagine a scenario. Okay, there is RH negative mother, and after conception, okay, the fetus is RH positive. Okay, now this RH positive blood during delivery, it get transferred into the maternal circulation. RH positive blood lead to maternal circulation. Okay, so what happens, the antibody is formed, antibody against Rh antigen formed. Okay, now when antibody against Rh antigen is formed, then next pregnancy happens after some days. Okay, next pregnancy happens, and during next pregnancy what happens, again Rh positive fetus formed, and when Rh positive fetus is formed, the antibody against this Rh positive get transferred from through placenta. Okay, it get transferred through placenta. Now the movie start. So what happens, this antibody entered into the fetus. Now here is the fetus. Okay, the antibody has entered into the fetus, antibody is forming through umbilicus. Okay, here is the antibody, the danger antibody, they are coming into the fetus. Now what happens, when this antibody comes, it react with the antigen, the Rh antibody cross react with the Rh antigen. When antibody and antigen they get combined, they form the antibody antigen complex. Okay, so when the antibody antigen complex is formed, what our body does, in this complex gets removed by the reticuloendothelial system. Okay, this get removed by reticuloendothelial system. Okay, so where this antigen Rh antigen is present, it is present in RBC. Okay, this RBC is having the Rh antigen in the fetus blood. Okay, now the antibody has come. Okay, and what antibody has does, this combined to the Rh antigen, and then antigen antibody complex has been formed. Okay, then antigen antibody complex has been formed, and this is removed by the reticuloendothelial system. Clear up to this? Now when a lot of antigen antibody are formed and a lot of antigen antibody, this which is present in the RBC, okay, this RBC get removed by the reticuloendothelial system, so the level of RBC will be decreased. Okay, there will be decrease in the level of RBC, and what happening here, due to the antibody and antigen complex formation, there is having a lot of destruction to this RBC, and number of RBC is decreasing. So what is happening, there is RBC destruction. Now when this RBC number gets decreased, what the body thinks, that there is decreased number of RBC, so what we have to do, we have to increase the production of RBC. So what needs to be done, erythropoiesis. Okay, so erythropoiesis starts happening due to RBC destruction, RBC level number decreases and erythropoiesis started. Erythropoiesis started. But this is the time of emergency and the body needs a lot of RBC to compensate this situation. And we know that while a factory is preparing some item and the production needs to be increased, then what happens, a lot of bad quality product will be formed because the production has been increased, and the situation is very critical and a lot of RBC is needed. Similarly, a lot of in nucleated RBC get released into the circulation. They do not get time for the maturation. Okay, the RBC do not get time to get mature. So without being mature, they are pushed into the circulation of the body. Similarly happens in this fetus also. There is happening on RBC destruction, RBC level decreasing, and the erythropoiesis started, and a lot of nucleated RBC they get released into the circulation. Okay, the nucleated RBC get released into the circulation. Now, are the nucleated RBC capable of transporting the oxygen? No, they are not, because they are defective. Okay, so the oxygen transport, it will also be defective. Okay, so oxygen transport will be defective. And one condition also there, that when this RBC getting damaged, a lot of hemoglobin gets converted into the bilirubin. Okay, so this hemoglobin get converted into bilirubin, and this bilirubin are unconjugated bilirubin. Okay, unconjugated initially there, and most of this bilirubin gets secreted into the maternal circulation. Okay, gets secreted into maternal circulation through placenta. Okay, through placenta. So at that time, will the fetus get jaundice? No. Why? Because this unconjugated bilirubin, it get transported. Okay, this unconjugated bilirubin start getting transported to the maternal circulation through placenta, and the level of bilirubin do not get much higher. Okay, due to which the baby do not get jaundice. But but as soon as the baby get born, and the umbilical cord is clamped, what happens? Will again the transport of bilirubin uh, be continue through the placenta? No. What happens? This bilirubin starts concentrating within the fetus. Okay, within the baby. So bilirubin starts concentrating in fetus. Now there is no any alternative way to remove this bilirubin from the fetus body. So what happens? The jaundice occur. So what happens? The jaundice occur. Now when this jaundice occur, what amount of bilirubin is necessary to cause jaundice? We have to know. That is, if more than 20 mg per 100 ml bilirubin, if more than 20 mg per 100 ml bilirubin crosses the blood brain barrier, okay, then what it does, it start damaging the brain. Okay, it start damaging basal nuclei of brain, due to which cornic tears happens. Cornic tears happens. Okay, so this is the pathophysiology for the formation of the cornic tears. Okay, now there is again one thing happening. It is that the oxygen transport has been defective. Okay, so there will be what? Tissue anoxia. There will be tissue anoxia. Oxygen is not getting transported to the tissue, due to which the body starts the glycolysis process. Okay, this Krebs cycle do not happen, and what happens? The glycolysis, and during glycolysis, instead of going the pathway towards the Krebs cycle, it get deviated to the lactic acidosis, due to which metabolic acidosis happens. Okay, due to which metabolic acidosis occurs. Now during this process, what is happening? The placenta thinks that I am not able to transport good amount of oxygen to the fetus. So what I need to do? I need to increase my capacity. Okay, I need to increase my capacity. The placenta thinks like that. So what placenta does? Placenta hyperplasia. What happens? Placenta hyperplasia. Why? To increase the oxygen transport. But the placenta do not know that I am not getting defective. There is defect in the RBC production. Okay, there is defect in the RBC production, and there is being a lot of RBC destruction. The placenta do not know this, and the placenta, what it does? Placenta hyperplasia. Why? In order to increase the oxygen transport. So the placental tissue hyperplasia occurs. Why? To increase oxygen transfer. But what defect is there? Is there the defect in the oxygen transfer? No, there is defect in the oxygen transport. The placenta, if this is the placenta, oxygen is reaching in a good amount from the maternal circulation into the placenta, but this umbilical cord attaching the fetus, problem is here. Okay, the problem is here. The oxygen transport within the fetal circulation is rapidly decreased due to the RBC destruction. So the defect is not here, the defect is here. But what placenta is doing? Placenta is thinking that the oxygen transport is defective, so it is increasing the placental tissue hyperplasia to increase the oxygen transfer. Now, do you think that will that help in the oxygen transport? No, because the oxygen main problem is within the fetal circulation. Okay, there is the RBC destruction. So instead of doing that, what happens? The fetal anoxemia. Instead of doing that, what happens? Fetal anoxemia. Now when this fetal anoxemia happens, there start occurring the fetal hypoproteinemia. Okay, fetal hypoproteinemia. Now when this level of protein also decreases, what start happening? Edema starts to occur. So generalized edema start occurring, leading to formation of ascites. Okay, ascites, hydrothorax. Okay, and this condition is known as hydrops fetalis. This condition is known as hydrops fetalis. And if this condition starts getting worse, then due to the heart failure, fetal death can occur. Okay, so if this condition get worse due to cardiac failure, fetal death can occur. So I want to ask you that is this occurring in the first pregnancy? No, this is not occurring in the first pregnancy. Is this occurring in the second pregnancy? Yes, it can happen. In the second pregnancy, the antibody formed within the maternal circulation, if it is in a very high amount, okay, if it is in very high amount, such condition can occur in the second pregnancy. But if the second pregnancy is okay, then there might be mild symptoms. Okay, there might be mild symptoms within the fetus, and this condition can be continued up to 6 weeks. Then after that, the antibody will be not available for destruction of RBC, and the condition of the fetus and the condition of the baby improves. Okay, but if in the subsequent pregnancy, like in third pregnancy, fourth pregnancy, if again this condition is not prevented by giving the NTD injection, then yes, the fetal death can occur. Chronic tears can happen. Hydrops fetalis can occur. Okay, so these are the conditions which are occurring in the subsequent pregnancy. Now, do we have any investigation to identify or to diagnose this condition? Yes, we have investigations. The first one is ultrasonography. Okay, and it is one of the best investigation. Okay, so during ultrasonography, what we can do? We can detect edema. We can detect edema in where there is generalized edema formation. Okay, so we can detect edema in skin, okay, scalp, pleura, or pericardial, pleural or pericardial effusion. We can detect through ultrasonography. Also, there is one position called as Buddha position. Buddha position. This is the position of fetus with halo. Buddha position of fetus with halo around head to 80 meters scalp. Okay, 80 meters scalp. And the due to the erythropoiesis, do you know that erythropoiesis where it is happening? In the adult one it is happening in the bone marrow, but in the embryonic state, okay, in the fetus stage, this erythropoiesis it happens where? It happens in spleen and liver. Okay, it happens in spleen and liver. So what we can see through ultrasound, we can see that the spleen and liver are enlarged. Okay, the spleen and liver are enlarged. So this is the investigation we can do. Now, how can we prevent these conditions? Okay, so for prevention, we give anti-DIGG 300 microgram intramuscularly within 72 hours following delivery. Okay, so following delivery, how much injection we give? We give 300 microgram intramuscularly anti-DIGG injection. Okay, but if this dose has been missed, okay, we can give this dose up to 28 days. Okay, if missed, actually it should not be missed, but if missed, it can be given within 28 days. So who are the females, those who will get this IgG anti-IgG injection? They are when, what are the conditions? So when baby is Rh positive, okay, when direct home test is negative, and when the baby's RS condition cannot be determined. Okay, when baby's RS condition cannot be determined, we can give this anti-IgG without any harm. Okay, can be given without any harm if baby RS condition cannot be determined. Actually, I have talked in the beginning that during the spontaneous abortion, okay, either spontaneous or this induced abortion, okay, there is also the chance of leaking of blood into the maternal circulation. Okay, so the conditions like, conditions like abortion, okay, induced or spontaneous abortion, ectopic pregnancy, molar pregnancy. In this condition, we give how much? We give 50 microgram of anti-D immunoglobulin to the female. Okay, but if the pregnancy crosses more than 12 weeks, okay, if pregnancy crosses more than 12 weeks, then we have to give this amount of immunoglobulin. Okay, so 300 microgram immunoglobulin. One thing we should know that this 300 microgram immunoglobulin, how much blood it prevent? So it prevent from 30 ml of fetal whole blood. Okay, we are very curious to prevent the 0.1 ml of blood, okay, into the maternal circulation. But we are giving how much dose? We are giving 300 microgram intramuscular dose, and this dose can prevent 30 ml of fetal whole blood, okay, 30 ml of fetal whole blood. So if we give 300 microgram, it will be more safe, okay. So we give 300 microgram. And for the dose estimation, there is one method also. For the dose estimation, there is one method. That test is called as Lee-Haber-Betke test. Lee-Haber-Betke test. So it gives one formula based upon which the dose is calculated. Now, one thing I would like to say that even after giving this 300 microgram injection, there is failure of 1 to 2%, okay. So if we give postpartum injection, still there is failure rate of 1 to 2%, okay, failure rate of 1 to 2%. So in order to decrease the failure rate, okay, what we give one dose of NTD, that is 300 microgram at 28 weeks of pregnancy. So if we give additional one dose of NTD 300 microgram at 28 weeks of pregnancy, then the failure rate, it decreases to 0.1%, okay. And the next dose is given after the delivery, okay. If the single postpartum NTD injection is given, there is a failure rate of 1 to 2%. Why? It is due to there may be antepartum hemorrhage, okay. There may be antepartum hemorrhage, so there can be failure. So we give initially one dose of NTD, okay, in order to decrease the failure rate to 0.1%. So by this the topic of hemolytic disease or erythroblastosis foetalis completed. Hope you enjoyed the video. Share this video to your friends if you like this, and ask the question in the comment box if you have any doubt. Thank you so much.